Thank you, Madam Chair. As Executive Director of the International Network of People Who Use Drugs, which is the key international NGO for one of the key affected populations, namely people who inject drugs, I welcome references in the report of the co-sponsoring organisations to one, the impact of stigma and discrimination against people who inject drugs, and the role that it plays in creating barriers to services. Two, the recognition of the importance of empowering people who inject drugs to their own peer organisations, and the key role that it plays in the development of appropriate, effective policies, services and programs. However, stigma and discrimination does not exist in a vacuum, and nowhere is the link made between stigma and discrimination of people who inject drugs, drug control regimes, and oppressive legal environments, and the ways in which these two are currently shaping the epidemic, such as occurred as new infections up in sub-Saharan Africa, the use of non-sterile or shed syringes. Indeed, in some populations of injecting drug users, notably in the Eastern European and Central Asian region, prevalence rates are as high as 85%. If we are to make significant progress in stemming the growth of the epidemic amongst people who inject drugs, we have to recognise the need for enabling legal environments, as the thematic segment makes it abundantly clear. We work very closely with our fellow affected populations, namely sex workers and men who have sex with men, on the many issues and challenges we face in common. These range from stigma and discrimination, lack of appropriate services, and criminalisation. It is time for universal action that is called for by the recognition that it is only supportive legal environments, which are the only ones in which key harm reduction interventions, including needle and syringe exchange programs and opioid substitution programs, can flourish, so we can make significant progress in halting and reversing epidemics amongst people who inject drugs. Given that outside sub-Saharan Africa, the epidemic is largely being driven by the use of non-sterile or shared syringes, this would in and of itself be a significant step towards getting towards zero new infections. As such, the ways in which the legal environment impacts on the HIV response is unambiguous. There is substantial flexibility around the world in applying and interpreting new drug control regulations, and we welcome this innovation and flexibility. There is an urgent need to draw together the learning from these different models that truly demonstrate when the legal environment is enabling rather than oppressive, and when pressures are removed people who inject drugs in drug schemes, then health improves, engagement in needle and syringe programs and opioid substitution programs can double, and HIV rates among people who inject drugs can drop by half within 5 years. I commend those countries that are exploring new models for decriminalising people who inject drugs, and urge the UN family and member states to reduce the contradictions between, on the one hand, the HIV public health approach, which is rooted in a commitment to human rights and a recognition of the need to end stigma and discrimination, and on the other, the drug control regime, which does neither but in fact exacerbates the epidemic. There is considerable scope within the Drug Control Conventions for innovation, which many countries have explored to create more supportive legal environments for people who inject drugs. These innovations include, but by no means limited to, heroin prescribing programs, safe consumption rooms, decriminalisation of people who use drugs, the support of peer-led organisations for people who inject drugs to initiate and carry out education programs and conduct research, to the implementation of the comprehensive package of harm reduction programs that is identified in the technical guidance for reducing HIV amongst people who inject drugs. It is notable that those countries that have explored the latitude offered by the conventions, either early or comprehensively, and preferably both, have managed to keep HIV rates amongst people who inject drugs at extremely low levels. On the other hand, we note that other countries, notably in the Eastern European and Central Asian and Southeast Asian regions, have maintained extremely repressive legal environments which encourage stigma and discrimination against people who inject drugs and prevent the rollout of comprehensive harm reduction measures, crucially needle and syringe exchange programs and opioid substitution therapy. There is a direct correlation between such repressive legal environments and high prevalence rates amongst people who inject drugs. To conclude, the epidemiology demonstrates the link between repressive legal environments and high prevalence rates amongst people who inject drugs. And it is clear that the converse is also true. We know too what needs to be done to prevent transmission and even reverse the epidemic amongst people who inject drugs. The evidence supporting the efficacy of needle and syringe exchange programs and opioid substitution programs is irrefutable, and the role that stigma and discrimination play in marginalising people who inject drugs, keeping them away from services where they exist, is evident. It is time to act, and time to act boldly. Thank you, Madam Chair.